I must say that I must thank really all of you for being here with me, because these are some of the cases which, we have been preparing for quite some time, and then trying to see that how best I can sort of share with you other people. These are the areas where I had so much of a problem in dealing with it over a period of time. The only advantage I had being some data with me over a period of years, which I'm going to show you. Really, thank you very much. Last few sessions have been very a big learning experience for me, and some of the questions which have come as it's really fantastic questions, beautiful questions. Something is like a totally out of box kind of questions which have been thrown at me. When I say that, these are open for questions, it's not that I'm going to answer, I will be able to, or I'm capable of answering every question what you throw, but let us share something. Today, I'll be mainly discussing two cases, one case in a little bit more elaborate way, but I'll also be running through 2-3 other cases which we have done sometime before. Especially the case summaries which come in a table form. Some of you, if you have logged in a mobile, it may be a little bit difficult to read that fine print. If you can have a laptop in hand, I think that will be very much better, because I tried to put the entire case in one slide and try to discuss what are my insights and then what I'm going to learn from you. So with this, this title is this one particular patient who told me, and then he said, "Doctor, I have bipolar," where I was feeling that it may not be. So let's move on to the topic. I think some of you are there with me in the last few sessions. Some of you may not be there. This is the case I discussed in my very first, in the sense, second session, where I'll briefly run through for some of you who are not there before with me. This patient was around a 30-year-old man who was seen by some other psychiatrist in 85, diagnosed as bipolar, first episode mania, put on lithium, and he came to me in 89. I continued lithium, taking the diagnosis of bipolar disorder. But since 89 till 2020, I have not seen any episode of mania. So briefly run through, after 10 years, I stopped lithium, then put him on lamotrigine because there are brief, milder symptoms of depression, no episodes. Then again, after that, lamotrigine also stopped. Last 15 years, he is on some small dose of escitalopram on and off. I discussed in 2 sessions. This is one of the comments somebody made. Did lithium cure bipolar disorder? It's such a cure. It's really, I never could think about something which can cure bipolar disorder. If this point has come from an youngster, I love that. If this has come from a very senior person, I can understand the sarcasm behind it, but that is a fact I put forward. After 1985, this man is now about 60. He didn't have a single episode, and we had some discussion. And then second is this case which I have discussed. This is a young person, 23-year-old. I saw him first time with a grandiose mania in 2014, a BTech graduate. I treated him with risperidone, then put him on lithium. And in the last 6 years, he's on lithium, 800 milligrams, and he didn't have any episode which is continuing. So the comment here is that, is lithium in the process of curing bipolar disorder? This is on the lighter side. I'm not talking about it very seriously. These are the 2 cases which I have discussed in the previous discussions. Now, we'll go on to the today's case. This is first I saw about 6 years back, October 2014. An young lady of 22 years. And then she walked into my clinic saying that for the last 6 years, She has not been doing well. That's what the parents told me. On and off, there are some symptoms which she has been having, seen by some other psychiatrists in some other city, diagnosed as having bipolar disorder, and with various treatments she has been going on. When she walked into my clinic, I had a doubt about this depression, but I was not sure about the bipolar disorder. So the first day in my clinic, my diagnosis, Cori bipolar disorder depression, Cori DMDD, because this started around the age of 15. This is the differential diagnosis I entertained. And here, let me tell you, these dots and then later other diagnoses for me, usually in the first time when somebody comes, I'll make a diagnosis. For a period of time, for a period of 1 year, 2 years, if I change my diagnosis, if it's something else come, I'll put these dots as kind of an indicator to me and make this diagnosis. Even today, the diagnosis still query. You may be thinking, what is this man doing after 6 years of it? He still put a query there. He is not able to make a diagnosis after 6 years of following with the patient, but that's a fact. Some other history that the patient's sister had a postpartum depressive episode who was treated by me and is completely all right. And both the father and mother, parents are consanguineous parents, and then there's a significant OCPD, obsessive compulsive personality disorder trait, which are very, very important in this particular case because quite a lot of times my problems were in that interaction. And the paternal first cousin had some history-wise, maybe a personality disorder, maybe a depression. I was not very sure about it. And this girl also had a premorbidly, which is more suggestive of very strict, rigid, and then like kind of very particular about things, very punctual, systematic, and then short-tempered. The small things can disturb her, very argumentative, hold on to something, doesn't leave it. That's a kind of a personality. No psychotic features, irritable, functional status. This is broadly the GAF, which is. So this is at the time of first presentation. A girl of 22 years, unmarried girl, having the problem for the last 6-7 years, seen by somebody else with a diagnosis of bipolar disorder, currently in a suggestive of a depressed state, and then come to me. This is my differential here. I was not able to make a diagnosis. This is the family history. This is a premorbid. Because this has been going on for the last 5-6 years, I straight away said that admission, because I'm not sure about the diagnosis. You please get admitted, then we'll evaluate and then see that. So we admitted the patient, maybe fairly detailed evaluation, but at no point of time I could get any specific episode in the past, which is clearly suggestive of a grandiose, elated, spending more and that kind of a manic episode I couldn't get, but the episodes of depression, and also irritability, that's why. So I left it like that after that. Now, sir, this is the most important slide. Actually, if you look at this, 2014 to 2020 till this month, everything of what is summarized in this, I think some of you who have attended previous webinars, and then you know that how I collect my data. This is a follow-up data, which comes in 5 columns. This is a data follow-up. This is the current status, whatever is the change. This is the medication, this is the dosage, this is the functional status. This is how I keep following it up. Now I'm going to share with you whatever happened. So I made a diagnosis of Cori bipolar disorder depression. And then we started her on this medication, valproate, because I'm not convinced, but still I started a so-called mood stabilizer. And this combination is actually, this is a OFC, olanzapine fluoxetine combination, but I don't use it much, but I use this, like on the slightly, replacing fluoxetine with escitalopram. I started the patient on this. This is about a month's time, like November, maybe by January, she showed 90% improvement, and then she's only on escitalopram. Now, you started on valproate and olanzapine and this, why only escitalopram? Once the patient became all right, there was increased weight and also hair fall. And then the patient was saying that refused to take valproate and then olanzapine. I said, okay, I'm not also very definite about the diagnosis. I stopped that, put the patient only on escitalopram. Here, previously somebody diagnosed bipolar disorder, but I'm not convinced. So some of you may object keeping the patient on that. That's the reason. So doing good. Now, after January, she went and stopped the medicines and then came back to me in August with a mild relapse, not a significant relapse, but mild relapse. Here, sir, The diagnosis of bipolar disorder, depression holds good, but I started her on only escitalopram because I do that, and she responded also. I started on that, but she didn't really respond after about a month's time, only 50%. So here I thought that maybe this is a bipolar depression, not responding to SSRIs. So immediately I changed to lithium. And she had thyroid also was there, very mild. So I started on that both. So by October, she came with a clear-cut, definite, here there was a mild relapse, a clear-cut, definite depressive symptoms. So almost about a month, 3 weeks after starting lithium, as there was not much of a response, I went back to escitalopram also. Here, let me clarify. Even though quite a bit of discussion goes on in the management of bipolar disorder, and then there's one group who strongly against the prescription of antidepressants. I do prescribe antidepressants in spite of all the queries. I do prescribe fairly liberally. Here I restarted because patient has responded there, restarted, and then within 2-3 months, by January, the 90% improvement. So here if you see that because the patient has improved, I was not very definite about the diagnosis of bipolar. Slowly I started reducing lithium and then stopped it. So the first episode, bipolar depression, valproate, olanzapine, escitalopram, but which was stopped, and with escitalopram she was doing well. After about 1 year, she had a relapse. I started on lithium, which didn't seem to help much. So I added escitalopram and it did well. And then next to 8-9 months, patient did very well only on escitalopram. To here. Even though we talked about some discussion in between, first what I thought is that this one, because now let me finish this and then we can take up the questions on this particular case. So 16 September, and then September 16, she came with a presentation which is highly irritable. There are a lot of other symptoms, but the predominant thing is irritable, argumentative, and then now shouting, screaming. So I had a doubt whether this, because there's always one point here, always there was a diagnosis of bipolar disorder which was made in the past, which is always hanging on my head, even though I'm not convinced. So I put it as a query. And then because this irritability, it was so much, I started the patient on risperidone. I didn't start on lithium, but I started on risperidone and levacetone, and then increased dose to 4 milligrams and 80 milligrams. But after almost about a month, there's only 50%. And here, by the time she came to January, 3 months later, she presented with a definite depressive symptoms. Here, the depressive symptoms were not severe. It's a very, very vague picture. Predominantly irritability. I was thinking maybe possibly mania. Here depression has come. I restarted escitalopram. Patient did very well. 90% improvement. This is November 2007, 90% with escitalopram, 20 milligrams. And then within about a week or 10 days, father comes and says that again this girl is having a significant problem, and then again the irritability, argument, and then the problems is the predominant thing. So I was wondering, once again a doubt whether it is another mania, especially look at here. There is a past diagnosis of bipolar disorder. Patient is only on escitalopram. All of you can say that this could have precipitated mania. Fine, possibility is there. So I started on risperidone. But I kept escitalopram because previously, it didn't work for me. But within a few days, I went up to risperidone, increased the dose to 12 milligrams. At this point of time, patient was admitted. This point of time, let me tell you, father came and told me that she is in the phase of mania. Patient is extremely irritable, screaming, argumentative. After admission, that week, none of the people who are working with me can forget that. She had an altercation with one of our doctors, and she flew into a rage, the kind of argument, and then screaming in the ward, shouting. She was demanding that I go there and apologize. She was demanding that the staff member should be suspended. And it went on for 2-3 hours. Finally, I had to go there at around 8:30. She gave me her mouthful. It's mainly around that. Now, how can your staff behave with me like that? How can they do something like that? It is the only thing around that. So now, like, you see, mostly the picture of this and this and this, nothing else. So we have increased the risperidone to 12 milligrams. So it's about another 2 months, 3 months. Patient is still maintaining like that. Not much of a change, slightly better, slightly again like this. So at this point, I added vilazodone. Vilazodone, that time, it's only a trial. I thought, okay, let me try with vilazodone because escitalopram, always the worry is that whether I can produce a switch. So vilazodone I tried, but it really did not work. And March 2018, she presented with a clear-cut depressive symptoms. Let me tell you, here again, she presented with clear, because here, there are some depressive symptoms, but more of irritability. That's why the problem. Here, she came with depression. Again, came with depression. So vilazodone, I increased it to 40, not much of a change. So I added escitalopram. Within another, now like in a month, there's a significant change. But this depression episode got prolonged. It started sometime, let us see that 2017, November, the problem started, and it continued and continued even till May 2018. I had to add nortriptyline as tricyclic and also olanzapine as sort of, I thought maybe at least some cover for the, now like, if at all she is going to switch. With this combination, she came to 90%. So here, 90% is almost complete recovery. So if this episode, you see that it started sometime, let's see that if you take this episode in March, it took almost about 3 months for her to come out of it. If you think this is the episode it started, it almost took 7-8 months. So this episode of depression in about 2 months, here again in about, all right, hardly 2-3 months she recovered. Here she took a long time. This took almost about 5-6 months. Right? Now, once the patient has recovered from depression, I started pulling down nortriptyline because we are always worried that tricyclists can produce more switch. So gradually this reduced and then nortriptyline was completely stopped. Patient was only on escitalopram at this point of time. That is 2018 November. And she continued like that, maintained the improvement till May 2019. But again, 2019, October, again the similar picture as it was here, as it was here, as it was here. Once again, the picture was predominantly irritability, argumentative. And this time, the funny thing is, that is why I've titled it as that. Patient herself walked in saying that, "Doctor, I have mania, please admit me." I was not very sure about that, but patient walked in. So at this point, I said, fine, we admitted. I started on lithium quetiapine. I think all of you are quite fine with me about this, starting these things, now like on patient has mania. But in 2 months, she came into clear-cut depression, and this thyroid problem again flared up. Here it was only 25 micrograms, it was 75 micrograms. And then here, patient is drowsy. Only after I started escitalopram, patient has come to 90% improvement. That is in this March 2020. Then she was drowsy. Slowly I was reducing quetiapine, and then now like thyroid could be slowly removed, stop lithium. And then finally, the latest was in 2000, just about 10 days back. All along, this lady was a software professional. She has been working all along. When she came to me last time, she said she was asked to resign the job. I said, why? What happened? You're doing much better now. It's about 80%. Doctor, I was not functioning well. This period, I've been warned that your functioning is not good. Last year also, there was some problem. So finally, they were not happy with me. They asked me to resign. And then I resigned. This is the story of a lady who started from 2014 to 20. Now, let me run through the summary of this here. She walked into my clinic in 2014 with a previous diagnosis of bipolar depression, bipolar disorder, which I was not convinced. If you look at this is November 2014 depression, then October 2014, November, October, then this is September 2016, 14, 15, 16, the irritability, this is September, then again 17 November, October, September, and again November here. And if you look at here, it's again October. If you look at this, all the episodes, whether they were precipitated or coming at that period. Do we call this something like a seasonal? I do not know. Only after looking this, like an entire thing, I could make out, okay, this looks like that, but otherwise I was not aware of. November, October, September, and again November, and again. So this could be one of the presentation of recurrent depressions in the seasonal. Right. Let me put it why I took up this case. Here depression improved with escitalopram. The second episode, mild relapse, and then here escitalopram, she did very, this is one of the shortest periods, she did very well. She completely recovered. Here the problem is 2016 September when she presented with this, I had a doubt whether this is mania, which is actually not. This is again a presentation of depression with irritability as one of the symptoms. And as I told you, the premorbid personality and the parents' premorbid personality, lot of significant interpersonal relations, which gave me the picture of more of irritability, and that is why it's mistaken. See, if you look at this, started in September, but only in January, the depressive symptoms became very clear. So this delay is mainly because I removed the escitalopram and put the patient on risperidone. That is the reason why it got postponed. Exactly similar picture if you see here. Patient presented with a relapse in November 2017. I was not sure about the diagnosis. And then with all this risperidone and then other not giving escitalopram, by March 18, depression became very clear. Again, the same thing here, October until January. So now the thing here is that when you are clear about the depression diagnosis, you treated with escitalopram and then patient recovered. Whenever there was a doubt, and this doubt was because of the diagnosis problem, like could it be bipolar and this mania, which is actually a depression with significant irritability manifestation and which has been exaggerated by the interpersonal problems between the patient and the parents. Completely the clinically, this is what the like a treatment. Obviously it got worsened. Again here, this is the treatment. Obviously it got worsened, it got prolonged. Otherwise, which should have been complete recovery in 2 months, it took 5-6 months. And again here, and finally it took its toll on this because functioning level, now here, this functioning level and delay is because of my risperidone. Here again, this delay is because of my risperidone. Because of this drug, probably not incorrect diagnosis, and then the fear of inducing mania with escitalopram, and the fear of this being a manic episode, started on antipsychotics, which did not help depression and got it worsened. And that is where the clear message every time here is that is where the diagnosis becomes important. And then this worry about, all the time worry about, could it be bipolar? If it is bipolar, am I going to produce a switch? And then that's a problem. Because of that, always you hold on to the drug. And this is the lesson. That otherwise, if it is simple recurrent depressive disorder, all these things would not have been there. Patient would not have got into this particular problem. This is what I feel in this particular case. And that is why I thought I'll present it. Now, at this point of time, if any of you, if there are some questions, yeah, right, some questions have come. Let me see whether I can sort of now like take up some of these questions and then talk about this. Right. Could the depressive symptoms not be result of hypothyroidism? Now, very first time when I showed you this, this one, it is arbitrary. There was no clear cut. The TSH was not very high. Now, like a borderline, that is very unlikely to be secondary to that. And then it's not one episode, multiple episodes. First 2 episodes of depression, you have started on valproate or lithium. Why? Perhaps intuition? No, sir. Definitely not intuition. This patient walked into my clinic with a diagnosis of bipolar disorder. I was told by the father, this patient is suffering from bipolar disorder. So bipolar disorder, it's a dictum is that you have to keep something, some kind of a prophylactic drug only under that cover you have to give. So reluctant starting valproate. Even lithium also, I was not convinced about mania, but reluctantly started. Right. You may ask me how long you keep on changing it. That is the clinician's dilemma. On one side, this is why all the time I'm keeping talking about it. The depression diagnostic criteria are the same. If it is simple MDD or RDD, your treatment is totally different. If it is bipolar depression, it's completely different. Not only just different, there's a lot of so-called should not be. That is where always, am I missing a bipolar? So let me start lithium. But lithium is not working. So go back to that, right? Why was escitalopram withdrawn when she was depressed? And at this point of time, always this question, these are the questions always keep bothering us. You continue escitalopram, whether there can be a switch. Let me see that now, like now here 26 and 9, 50%. Right, I start exactly. See here, that's a very correct question. This first episode, escitalopram 10 milligrams, she showed 90% improvement. So when there is a mild relapse, I started an escitalopram 10, but patient become worse. Definite depressive symptoms have come. So I thought maybe escitalopram is not working. Possibility is that increase it to 20 or go to lithium in a bipolar depression, which is supposed to be effective drug. That's why I put on lithium there. Whereas third event, you didn't put her on a mood stabilizer. Only in 2019, you reintroduced lithium. Exactly, sir, exactly. From here to here, I have been always bothered by, as I told, the diagnosis of Demokel, this one, bipolar disorder, hanging on my head. But I'm not seeing the symptoms. The only symptom I'm seeing is depression. Very definitely I'm seeing, but the only other picture what I'm seeing is irritability. I don't see any elation, grandiosity, but you don't know. Patient's father tells it's a bipolar. Previous psychiatrist diagnosed it. And finally, the patient herself walked in saying, doctor, I have bipolar. Imagine in this kind of situation, right? So far, so good. This treatment and all, if you're seeing, if this lady tomorrow definitely develops a manic episode, what is she going to tell him? She's going to tell, I have told you I have this diagnosis, but you didn't listen to me and then you treated me somewhere. I have the problem. You have to look at those things. So this is a clinician's problems every day. Textbooks do not describe that. I have to be careful about that also. Then, right, rating scales. Generally, I don't use much of rating scales because you know that it's a problem is, that is why this is, it's a crude. 80%, 90%, 50%, it's a crude one, but I don't use rating scale. This is a GIF. That's where I say it. 30, 11, 17, why was lithium not added, especially when she was irritable and in a rage? Right. So let me tell you, I will not add lithium like that. Every time I added lithium here out of my insecurity. Because here, she didn't improve with escitalopram. Let me try, I'll try lithium and then she's going to improve. Here, patient, this is the only time. This is the first time. And the second time only here. Because patient herself walked in saying that, doctor, I have bipolar. She'll come and tell you. If the patient, leaves me and comes to you saying that I told the doctor I have bipolar and he didn't start lithium. And then, so this is mostly that. I don't start, patient on just like that, just because irritability, rage. Why lithium was stopped in September 2016, in spite she was doing well, functional status was, right, sir, here, correct. Because I gave lithium, she did not show significant improvement. But when I gave escitalopram, she improved. Then why do I? If I was definite about the diagnosis of bipolar, I would have continued. But otherwise, I would rather prefer to keep the patient on one drug rather than keep 2-3 drugs. That is the only reason. Couldn't we do anything about the swings by constantly keeping on? This is not swings, madam. These are definite episodes, madam. In between, patient was completely all right, madam. I refuse to call this as swings. These are episodes. I don't treat swings. I treat episodes. But constantly keeping mood stabilizer. But I'm not sure about the diagnosis of bipolar disorder. And then at the end of it, every time I wrongly diagnose irritable depression as a possible mania, I delayed her recovery. Every time you see that. Here I delayed for 3 months. Here I delayed for 4 months. Here it delayed, which cost her job. If I had diagnosed correctly, leaving the bipolar disorder, simple depression, I would have treated with antidepressant, patient would have recovered, and poor girl, she would not have lost her job. This is the problems. There's a problem because she has been coming to me again and again. I was able to get back to that. Are mood stabilizers helpful in recurrent depressive disorders? No, sir. If it is RDD, I don't even look at it, very definitely. So good insight was the point that was going against mania. In the sense, I am a bit too conscious about making a diagnosis of mania only an irritability as predominant factor, because I feel that we are doing, that is, I feel that one of the major problems in the world diagnosis of bipolar disorder. Here it has proven me, not once. Possible mania, I put her on risperidone. Possible mania, I put her on risperidone. Possible mania, I put her on lithium. Every time she didn't respond and worsened depression, worsened depression, worsened depression. Only when I started escitalopram, this patient has improved. This is very clearly the picture what I'm seeing here. Making a wrong diagnosis, like it's costing me. What is the difference between depressive symptoms and negative symptoms? Schizophrenia? Let's not talk about it, sir. It's a totally different thing. Could escitalopram be combined with lamotrigine in the patient for preventing a relapse? Definitely. If I had thought that it's a definite bipolar disorder, I would have given a try with lamotrigine, but I was always doubtful. Then if it is RDD, I will not touch lamotrigine, sir. Why not consider olanzapine fluoxetine combination? It approved for bipolar depression? Yes, right. Correct. Yeah, very good question. Olanzapine fluoxetine combination. We look at it as olanzapine SSRI combination. Why there is no other study with olanzapine plus escitalopram or olanzapine with sertraline? Just because broadly it gives a guideline saying that olanzapine plus one SSRI seem to be effective. Fluoxetine is a difficult drug with drug-drug interactions. Fluoxetine is a problematic drug releasing anxiety. That is the reason I combined olanzapine and escitalopram. This question I have been asking, why only fluoxetine olanzapine? Why there is no study of olanzapine in this? Right, not triptyline. Why I used? See, clinical practice, sir. A clinician, when the patient comes again and again and again saying that, doctor, I'm not better, I am worse, we become desperate. In spite of all the so-called academic, I want my patient to improve. I want my patient to recover. I want to do something about it. Already, I have done something here. Nortriptyline is one of the tricyclics, which I don't use it commonly, but in this kind of situation, I use it. Lithium could have been added to escitalopram. Lithium could have been added to, yeah, right. Right. This is one of the problems. One of my problems is that I would, right or wrong, generally try to prefer a less number of drugs, one or two. Otherwise, sometimes it's difficult to have insight. Lithium did not seem to have helped her. That's why I removed, nothing else. Why was thyroxine? Exactly. Actually, it's borderline. It's nothing like a definite hypothyroidism at this point of time. But at this point of time, she developed this, which may be possibly my gift to her because of starting lithium. I don't know. She was not a definite hypothyroid. Lamotrigine with lithium. Right. Lamotrigine, I would not consider here with a doubtful diagnosis of bipolar disorder. Definite, maybe I would have. Lithium and induced, significant, sir. Especially women. Lithium fairly commonly induces hypothyroidism. Fairly common in the sense, not very frequent. Maybe let's say about 20%. It's there. Lithium induced is reversible when the offender is discontinued. I have seen this. I stopped lithium over a period of maybe it takes about 6 months or 1 year. I think hypothyroid states also come down and becomes normal. Can withdrawal of lithium itself lead to relapse? Yes, all these questions. But what I have given lithium is for a very short period. Why should lamotrigine be avoided in RDD? Good question, sir. But first of all, I will ask you, why should lamotrigine be thought about in RDD? Forget about avoided. Who told us to give lamotrigine is useful in recurrent depressive disorder? I do not know. It's useful only in bipolar disorder, not in MDD. As far as I know, that's what the things are. If there is any disinhibition during irritability, yes, I don't call that as disinhibition. It's a OCPD. They get a small, the spark is very, very minor here. And there's a bit of a problem with all of us. We sometimes talk a little bit loose and then talk. That is the reason. I don't blame the patient here completely. One of the whatever it is, the behavior which the patient did not like. No, I don't call it disinhibition, but that kind of, like, and the skin is very, very hypersensitive. I think OCPD. That's what I'm looking at it. Nortriptyline combined well with lithium. Nortriptyline, I don't want to continue for a long time. Despite being in escitalopram, all this, correct, irritability was there, but here, 90%. Here, 90%. She came out of it. Significant irritability was not there. See here, what I look at this is that depressive episode, there was escitalopram, well treated, mild relapse, I put on lithium, did not help, added escitalopram, recovered. Irritability, which also now looking back, I think it was a depressive episode, which I wrongly diagnosed as a chorimania and then put on risperidone and all those things, where it did the wrong thing and depression becomes worse and delayed. Again, irritability, again, this could be depression symptom, which I should have treated with escitalopram, but again, risperidone and all the things in the typical way we treat aggression. Again, it's delayed for another 2-3 months here. One more here, 90% with escitalopram and antidepressant. Again, one more. Again, patient herself saying that I put on lithium and again delayed. Every time here the irritable, argumentative, we immediately jump to the conclusion it could be mania and then start on antipsychotics or something. This lesson for me in this is that, number one, irritability could be a symptom of depression in a premorbid personality with OCPD, and especially the family members being OCPD. There's always no holding tightly to each other's viewpoint and then argument. Everybody wants to have the last word and it goes on. And that could be the reason. My mistake here, my mistake here, my mistake here. 3 mistakes here. Unfortunately, we don't have a diagnostic test. If there was a diagnostic test, absolutely, it would have no problem at all. And then end of the day, sometime back I said that sometimes our drug, here the functioning was disturbed. Functioning is disturbed. Functioning is disturbed because of my non-correct treatment by not giving antidepressant. Patient has to lose the job. I asked her, you're doing good now, what's the problem? Doctor, last 1 year and then something was, they are not happy, doctor. They were repeatedly telling me, asked. This is what. Now we say that functional outcome is not good. Functional outcome is not good because of my incorrect treatment. That's the thing. Does she have drug-induced mood episodes like in September 2000? Drug-induced, I don't know whether it is drug-induced. It's more of irritable. I look at it as another depressive episode precipitated in spite of being on escitalopram. That is what you can see the slide. In spite of being on that possibility of that. Exactly. I think this is the best question. Why was she asked to resign when she was doing well with escitalopram? This is exactly I asked. That's what I was telling, that she's doing 80%. She told that, not doctor, it's only last 2 months I was doing. This 3-4 months period, I didn't do well. Last year also I had a problem. They were unhappy. They asked me to leave. That's what clearly the answer came. Personality factors, I told you, OCPD. Psychosocial, exactly, OCPD in both the parents, and then constant, like kind of quarrels and then problems, which was the irritability predominantly. And fathers believe that this daughter has bipolar disorder. Finally, patient herself saying that I have bipolar disorder. What is the ideal treatment for RDD? Let's not talk about it, sir. This one is retrospectively, what do you think would have been best on 22? I think this is exactly, sir. What do you think would have been better here? And 22, 9, 16, what do you think retrospectively? Suppose today, there are 2-3 factors which will come into effect. Now, suppose the same situation arises here. How do I treat this patient? Oh, that's a fantastic question. Theoretically, with this kind of insight, what I had all this, I will definitely start the patient on SSRI, escitalopram. Maybe I'll increase the dosage and then monotherapy I would have treated. Most likely I would have been successful. But the problem, madam, problem here is that you can understand Patient says, I am bipolar. Relative says, I am bipolar. Previous psychiatrist said they are bipolar. You know why I keep talking all this case series? I'm saying that I have nothing against bipolar 2 or no, like in so-called mood stabilizers or prophylactic drugs. But when you say that completely don't give another drug, antidepressants, which is being useful here, that's a problem. I would have treated with antidepressants, but always the fear that maybe you made a wrong diagnosis, but I would have treated with antidepressant. Agitated depression, yes, a possibility of this thing. For long-term problems with the use of frequent antidepressant, TCS, I don't almost use it also, very, very rarely, I don't use it. Should we be cautious in labeling the diagnosis in the early course? Yeah, correct, cautious, but we have to make a diagnosis, no, at least a provisional diagnosis we have to make. This is something which I say that. We are medical people, we have to make a diagnosis, and we as medical people, we have every right to make a wrong diagnosis, but you have to make a provisional diagnosis. Without diagnosis, we are gone. Diagnosis indicates prognosis, diagnose directs therapeutics. This is what last time I told. Diagnosis directs therapeutics. If my diagnosis was RDD, I would have simply started the patient on escitalopram, she would have improved. Because my diagnosis is a Cori BD, I was hesitant doing all those things. That's a problem. Long-term issues with use of antidepressants, and maybe sometime later we'll discuss that. Long-term use. Why do we have to use long-term everything, anything? Let us treat the episode effectively. Let us see that. Most of the patients in mania have hypersexual. This patient did not have grandiosity, elation, excessive spending, hypersexuality, decreased need for sleep. None of this. Only thing was irritable, which is an important criteria in all the DSM and the ICD. What about mirtazapine? Right, sir. My favorite drug is escitalopram. That's the thing. We could have used mirtazapine. So these are the things. Let us stop here. So this case, take-home message is that patient was here with me for 6 years. Whatever your impression about me, at the end of 6 years, I'm still put a diagnosis of recurrent depressive disorder. I'm not sure about whether I'm sure. Most likely it is, but the possibility of this lady having it. This we have treated, escitalopram treated well. Here the problem with risperidone, mismanagement. Again, mismanagement, which cost her, number one, treatment, depression got prolonged for 3 months, again for 3-4 months, again for another 3-4 months, which she could have improved simply with one single drug like this. And beautiful thing is, looks like a seasonal. November, October, September, November, October. Except 2018, she had been having this every year, one episode. Clearly episodes. Because of my wrong diagnosis in September, it got postponed to January. Because of my wrong diagnosis in November, it got postponed to March. Because of my wrong diagnosis in October, it got postponed to January, the final diagnosis. 2 months, 3 months is quite a bit of a period for a young girl like this who is working. Right. The thing is that I'm sharing this because this is what is happening. And because this data is available, I could go back and then go back and come to some kind of understanding about it. Otherwise, sometimes, okay, right, it just doesn't happen. It goes like that. There will be a lot of other questions also. Thank you so much. I think you asked wonderful questions. Now, we will move on to the next. This is just a graphical description of it. This lady, the patient, supposedly started in 2008 to 14, not with me, with some other doctor, diagnosis of bipolar. 2014 came to me, responded well. 15 is a simple thing. I withdrew lithium and escitalopram. She did very well. 16, 17, 19, every time she had depression, the problem was irritability. And then I am confused here. Start lithium and stop it. Risperidone and then stop it. And then risperidone and stop it. And lithium and stop it. This is the major confusion. Because of my confusion, depressive episodes got prolonged. This is a definite blue color depression. This is a vagueness in there. Because I think it's because of my therapeutic lack of that, like a clear-cut direction in that it got delayed for such a long time. This is the message I get from this patient. Finally, it cost her fairly significant. We'll go on to the next patient. This is another male who has come to me. This is actually almost 12 years now. This boy, when he came to me, was 22 years. Age of onset is 22. That girl, age of onset was 15. Premorbid social. He had a paranoid and grandiose ideas. He was irritable mood. When he came, by the time he came to me, he was seen by some doctor. Generally, I don't start on typicals to start with, but he was already on that 1500. I also don't go up to 1500 of valproate. I start on 1000. This is the dose he came with. This is the time. Diagnosis, there is no doubt for me. I've seen him, bipolar disorder, elated, grandiose mania, bipolar 1. That's it. There's no doubt. So I started on this 2008. I started this patient, the same medication what he was on. This is the background. There's no family history. Yeah, there's no family history here. And these two patients I'm showing you here, one of the very good complaints. I can almost say that 95% of drug complaints, because this patient's family, one of the family members is a medical professional. She's very cooperative. And then the second patient, the first patient previously I talked about. Some of you may wonder, that lady has been coming to you for 5-6 years. You have been not treating very clearly. Why were they coming again and again to you? They would have gone to some other psychiatrist. That's a good question, actually. So I thought somebody will ask me. I treated her sister very well. She's doing completely all right. Only with the citalopram. My diagnosis, postpartum depression. I didn't have any of these doubts, and she's doing well. That is with the hope they are coming back to me again and again. So now we'll go to this patient. This is the background. Right. Once again, here is the story starting from 2008 to, right. This is the last follow-up. This is almost 11-year follow-up. Sir, please, here there's not much of a complication regarding diagnosis. Diagnosis is very clear, bipolar disorder. There's no doubt about it. I never had a doubt on day one. I don't have a doubt about it. But how the progression, in this case, I selected how the progression of the illness over a period of time, I wanted to understand this. That is what. Patient is, first she came with mania, and I told you, he was on valproate, chlorpromazine, and then trifloperazine. And within a month, 90% improvement. Slowly, I started pulling down the drugs. Pull down, right? I told you I'm not very comfortable with the typical antipsychotics. So when the patient is like this, I think that is 2008 is the time I think quetiapine was introduced and then approved as antimanic, antidepressant, and also prophylactic drug. So I think I keep doing this kind of experiments. I started the patient on quetiapine, 300 milligrams, a good dose. 2008, November. 2009, January, patient had depression. Clear cut. Depressive episode. I didn't change the drug because quetiapine was introduced into the market. Quetiapine was the drug for bipolar depression. Here, I don't have a doubt about the diagnosis. I just continued. Okay, let me see. I have to learn. Let me see. I continued the same 300 milligrams also. Only this has decreased. So within about not even a month, 3 weeks, patient has come out. Beautiful. So first episode mania improved. Second episode depression. I continued the same quetiapine. Patient recovered within about 3 weeks. And I continued. Then within a month, 17 March 2009, he had relapse of mania. Clear cut. So obviously, quetiapine is useful for mania also. So I added lithium. It is grandiose mania. One episode mania, depression, second. Here, when I started lithium, he already had one episode mania and depression. This is the third episode, second episode mania. I was perfectly right in starting this drug lithium. Quetiapine I continued because quetiapine also FDA approved drug for long-term prophylaxis. So I thought I'll keep the patient on both and let me see. And absolutely good dose. Lithium, sir, maybe I didn't mention here except once. Mostly I keep doing the blood levels every 3 months or 6 months. I try to keep between 0.6 to 1, 1.1, not very high, 0.6 to 1 mostly. This is 900 plus 600. I think most of you agree it's a fairly good dose. So March 17th, 2009, I added lithium. 30th March, 80%. So within 3 weeks, patient has shown a significant improvement with this. So I continued this. So March 2009 to 2010 November. So almost 1.5 years, patient was doing well on this combination of lithium and then quetiapine. I started reducing because usually after symptoms reduction, a lot of patients complain of drowsiness. So I start reducing quetiapine and then slowly reducing because the lithium cover is there. Fine. Then he did well for the next few months. 2011 June, he had a relapse of mania. This was slightly severe, so I admitted him. Here I want you to understand, note that patient was on lithium good dose and also some quetiapine dose when he relapsed, had a relapse of mania. Right? I admitted, added risperidone. Right, in about, this is June, in about 2 months, 60%. By October, he had a depression. When somebody has depression, especially if the patient is on haloperidol or risperidone, the first thing I think is that whether it is drug induced. So risperidone, if it is there, I'll try to pull it out very fast from 9 milligrams to 3 and then almost completely pulled out. So October 2011, he had depression, possibly this. So I removed risperidone. 2012 June, he had another mania. So when he had this mania, he's still on lithium and also on quetiapine. Because I had a doubt about risperidone could produce depression, I added olanzapine here. See here what is happening. From here all along, there are 2 drugs. Polypharmacy. Because with 1 drug, he had relapsed, I added second one. Now here 1 more, I added the 3rd drug. Right? Improved that. And I removed the olanzapine and again came back to lithium and quetiapine, 2 very well-known drugs in the prophylaxis. So June 2012, within a month, hardly 3 weeks, he improved. Then 16th February, he had a doubtful depression. I didn't add any antidepressant here. I didn't do anything. And then by April, he became quite significantly depressed. Here it is query depression. In about 2 months' time, I continued the medicine with the titration of the doses he became. At this point of time, I added vilazodone. I don't know. See, like these are some of the things which I do. Sometimes I want to try a new drug, test a new drug. So I said for 2 months he has been continuing on depression. Let me add a vilazodone, 20 milligrams. Here within 4 days he had mania. Sir, very definitely I say that this is very, very unlikely because of vilazodone. Just it's on 4 days. It's an incidental finding, but I kept it there saying that it could be. So again, he had mania. This mania which he had in 2016 April is a very severe mania. Now, if you see this mania he developed while on lithium 800, quetiapine 400 mania. I have to admit him. Then you see the list of medication here. I was really struggling with this boy. I almost never combine lithium and haloperidol. I am some fear about neuropsychiatric irreversible side effects, but here I had to do that. First time he had 8 ECTs. I never given ECTs all along, even though I admitted him here. First time, 8 ECTs. 8 ECTs, usually in our hospital it's a 4, 5, we stop it there. 8 ECTs. Haloperidol, lithium, trifluoprazine, lurasidone is added. It's continued and continued. Ultimately, when I see this 90%, when is this? March 2017. This boy's mania started in 2016 April. It almost took 1 year, if not 1 year, 9 months for this boy to come out of mania. It took such a long time. Almost 3 months he was in the hospital. 2 months he was in the rehab center, and he was on all these drugs. Then 2017 March he recovered, and this is a lithium level around that. And then after that, I slowly started reducing the drugs. Usually I do that. First thing is haloperidol is gone, then trifluoprazane, now like all these drugs one by one are removed. And the last I saw him was in October 2019. He was supposed to come. Usually once a patient is all right, I give them for 4 months or 3-4 months. In this lockdown and all, he was not able to come. Now he's back in his business. This boy is from nearby state. He's only on 800. So from 2017 July till now, he's free of the episodes. He is euthymic. Now let's go back to this. 2018, 8, 2020, how many episodes he had, sir? He came with mania, 1, 2, 3, 4, leave this, 5, 6, 7 episodes. 7 episodes in a period of 12 years. Textbook description of bipolar disorder says that average number of episodes is about 3 to 4 in a 10 years period. This boy almost had a similar thing, right? But now see that. This is one patient where in spite of this depression and then depression and then depression and then depression, I have not given any antidepressant at any point of time. Somehow I could manage with these 2 drugs, except this was given for 4 days. Yeah, that's immaterial, throw it out. In this 12 years period, I have not given this patient even once antidepressants, in spite of different episodes of depression. Now let us see from here. From 2009 March, he is on lithium continuously without any break till 2020. 11 years, not a single day he was without lithium. While on lithium, he had how many episodes? 1, 2, 3, 4 episodes. 2, 3 manias, and then 1 depression, definitely 1 possible depression. While a patient is on a prophylactic drug like lithium for 11 years, 2009 to 2020, he had 3 episodes of mania and then 2 episodes of depression. In this particular case, do you say that lithium is effective here? Lithium is useful? I do not know. I do not know. And then initial episode, this may be one of the patients where you can say that repeated episodes give severe episodes. First episode mania improved in 1 month. Depression you see here, hardly 3 weeks he improved. Relapse of mania again, exactly 13 days he improved. Again here, just 2 months he has improved, which took a little bit longer time. Here, this mania, June, July, again 1 month. All these manias and depressions, except 1 episode which took a little bit longer time, he recovered in a period of about a month. I've never given antidepressant. It's mainly lithium, quetiapine, olanzapine he was getting. Within about a month, mania improved, depression improved. But when it came to the latest episode, it took 1 year. You mean to say that suddenly the severity has increased here? What some people talk about neurobiological progression and then increase it? I do not know. Very unlikely. But what is the reason? I cannot explain. But why so many episodes while on lithium? Then how do you talk about the prophylactic efficacy of lithium? One of you may say that if lithium was not there, you would have had 10 episodes. No, let's not talk about this. He had a textbook description of 6 or 7 episodes. But now, at this point, he came to me at 22 years. Now it's about 33, 34. The boy is doing good now, euthymia. Last 3 years. It didn't leave any scar. It didn't leave any residual deficit. It didn't leave any functional outcome. He's very good. He's in his own business. This is what I talk about. I'll come to it. Bipolar disorder, good prognosis. In spite of being 12 years on this, he recovered and he's doing good. The other girl, he was all along doing the software job. Only now she was asked to resign. She's going to go for a job. So now, how do we explain this? So many relapses, recurrences while on lithium and then quetiapine, 2 very good drugs which are supposed to be, lithium is a gold standard, quetiapine is supposed to be a very good drug. And while on that, why such a severe? I have not stopped lithium at any point of time. How do we explain this? I do not know. But at this point of time, If anybody asks me, see, while on lithium, he's been having a mania, depression, mania. Why are you continuing this? How do I answer any other colleague effectively that no, this drug is effective? Lithium is not an ordinary drug. It's a problematic drug in the long run. You have to monitor a lot of things. There can be significant side effects. How? If you remember the very first slide I showed, one episode of mania and then lifelong he didn't have. That is one. And this is a classical textbook description, but this is a little bit more severe. Now this boy is still, again, is doing this. Now let me see, like, what are the questions here? Let me see that whether there are any. This is Akiskal's case. Yeah, right. Okay, right. Clonazepam, right. That's a different thing. Previous one. How, right, previous one, let's not. This is Akiskal's case. I am sorry, sir. This is not Akiskal's case. This is John Kate's case. Akiskal, please don't tell me. He's the one who talked about 2.5, 3, 4.5, 5 and all those things. Fortunately, we have not accepted all that. We are even throwing out bipolar 2. Akiskal talked about 6, 7 and everything. That's not. This patient is a John Kate's mania, elated, grandiose, typically having textbook description of 4 to 3 episodes per year, all the time, very good recovery, ultimately very good recovery. That's it. How calm and for how long to treat it? Yeah, that's it. Now you please tell me. He came to me at 22 and now he is 34. This boy is going to live for another 35 years. And you want me to give lithium to him? For what? He has been getting 4 episodes. Without that, don't say that you would have got 10, 20 episodes. Don't say that. We don't know. Suppose, do I stop lithium? I don't dare to. What do I treat him with? That's a big dilemma. When you talk about 50 years of treatment, prophylactic treatment, these are dilemmas. How long? People say lifelong. All algorithms say lifelong. How common are the kidney-related effects on lithium? This polyuria, these are all, don't worry about it. Serious CKD with lithium is supposedly after 25 years of continuous usage of lithium. Generally, fortunately, it's not very common, but after 25 years, it's supposed to be significantly high, 8 times more high. I am now forced to keep one patient who did not respond to any other drug in spite of serum creatinine being 2. I put the patient on lithium and I'm continuing lithium. She's doing good. It's because I could talk to the relatives and then finally there's no choice. Only with lithium she has improved. But reversible, it depends on. Last time, I think before time I have shown some slides which are actually frightening. The histopathology of 3 months after starting lithium. But generally in the clinical, it's not so common. What to do if patient is stable on lithium but diagnosed having thyroid problem? I have no problem, sir. I'll start him on thyroxine. If patient is stable on lithium, absolutely no problem. Start on that. Patient is going to curse me saying that you have given me another disorder, you have given me another drug, which is going to be lifelong. But I'll tell them that, no, please, this is no problem drug. Thyroxine is no problem drug. Please take, I'll tell them. But if I find lithium not very useful or doubtful, I'll stop it. What is the experience with the risdone-induced depression? Very common, sir. Very, very common. Typical antipsychotics, haloperidol was the culprit. Newer antipsychotics, I look at risperidone. Very commonly we use, a lot of times when a patient with the bipolar disorder develops depression, first thing I do is that if he is on risperidone, I stop that. Quite a few times that gets relieved. We don't talk about drug-induced depressions. We only talk about drug-induced mania and then switch. That is the only switch. Why? This is also switch, sir. We have to talk about this. When the diagnosis of Bipolar was clear, why was mood stabilizer? Which one? Very much. He's on lithium all along. All along, he was on lithium. You can't find a better mood stabilizer, so-called by the lithium. Percentage of improvement subjective, yes. I think this is a very good question. This question, because this one I talked about 80-90%. Is it the subjective or objective? Good. See, because I don't do HAM-Ds and YMRS, here I do a combination, sir. I talk to the patient, I talk to the relative, and also mine. All three put together, I give a tentative value. You're right. It's not purely subjective. Patient says that I'm all right, doctor, in mania. Definitely, I don't do that. Sometimes patient is all right. Relatives keep saying that, no, 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 he still has to do something. He still has to. I also don't. So it's a tentative three figure. Patient, relative, and then mine together. We put it saying that when I say 90%, I tell them 90% for me is 100%. There's nobody who is 100% all right. I tell the patients also. So there's no 100% you find in this. Can mania be present for that long? Yes, yes, yes. I think absolutely brilliant question. You put the question back to me. Every meeting I keep asking that, what is the percentage of chronic mania? How many percentage of chronic mania you have in your clinic? And I say that less than 5%, less than, exactly. It's generally not the case. Very, very rare to go on for such a long time. Here also, let me open out a little bit more frankly now. Here also, is it prolonged mania? I didn't talk about it. Or sometimes because initially I had difficulty, I went on pumping the drugs. Haloperidol, triflupercin, lurazidone. Was it also creating some problem? That is something which we have to. But generally, mania is not at all prolonged. Chronic manias are almost not seen. Only it's nothing like only manic episodes need augmentation and all things. Why only here is such a severe mania? So why only lithium now? Definitely. Lurazidone, I am not confident, madam, as in today. Lurazidone, I am not confident about anything. As an antidepressant, I am not at all confident. Lithium, I have definitely. Why he was started with ECT? Because he was not improving with this combination of all this. Almost you see that 2 months have gone, so I started ECT. Why can't this be? And definitely, it's not. See, there are two things. You are asking me, this patient is an exception, right? It is an exception. In what sense? I told you, 12 years, he had 7 episodes, textbook description. He had manias grandiose, textbook description. Depressions, textbook description. 1 month or 1.5 months, he is recovering 90%, 90%, 90%, 90%. I'm writing bipolar disorder is an episodic disorder. Recovery is the rule. Absolutely. Why do you say, madam, this is an exception? Except this is prolonged, he again come back to normal. This is a slightly variation. It's not one of the exceptional stories. Slightly this is prolonged. And this data, because I'm living with this data, I could see all these things. If I don't have this, I will never have these insights. I would never have thought that irritability I have not done correctly in the previous patient. That is it. Second generation antipsychotic is a better choice in maintenance. Sir, this patient was on quetiapine for a good length of time, sir. Almost from here, all this you see. From here, 2008 till 2016, he was on quetiapine, sir. I have used quetiapine. It's not that I didn't use second generation antipsychotic. Why only lithium? Oh, right. You're forcing me to say one thing. I think sometime back I wrote an editorial, but for lithium, all the other mood stabilizers do not seem to be doing the job of mood stabilization. That's broadly my belief, man. Any stressors, I'm sorry, sir. Bipolar disorder, I look at it as a predominantly biological disorder. Stressors, this is not an exacerbation. Where is the exacerbation? Here clear-cut relapses, recurrences. I don't look at it as a clear-cut recurrences, which is a normal course of bipolar disorder. I don't bother much about the stressors here. Pharmacotherapy for bipolar disorder is mostly pharmacotherapy, maybe some counseling, psychoeducation, nothing more than that. Responded to lurazidone, why not try maintenance? Definitely not. Please, no. Number one, there is no evidence for lurazidone as a maintenance. Absolutely. I will not do. What basis? I can't leave lithium and then give this man lurazidone. Absolutely ridiculous. No, I don't have that confidence on the drug. I don't even try, sir. Clustering of episodes 9, 11, 12, and 16. Where is the clustering, sir? It's episodic 9. Yeah, right. 11, and then 12, 16, Like that. It's like every 3-4 years. In 10, I told you 4 episodes in 10 years is the textbook description. How effective and safe is lithium in adolescents? What is the alternate drug, madam? You're right. I would ask the second question is, first question is how effective. Latest evidence shows that risperidone is a better drug in the management of adolescent mania rather than lithium. Yes, you're right. Safety wise, we have to take precautions. Serum lithium level mostly, sir, as I told you, I cannot say what it is, between 0.6 to, I maintain in that level, 0.6 to 1 around that. That's a level. Why can't other mood stabilizer be started in this case? Yeah, that's again a very good question, sir. There is quetiapine, sir. Quetiapine is a prophylactic drug. I didn't give only lithium. I know what you're thinking about. I was talking about valproate. I will not give now. You're thinking about quetiapine. He's on quetiapine. He's on 2 drugs, sir, not 1. Definitely I have given. Lithium not added. 12 to... Yeah, that is, I told you, the patient came to me from outside. He was on valproate. So I was reducing valproate. And then later I added. Multiple breakthrough. I don't call anything breakthrough episodes in bipolar disorder. They are episodes. Second mood stabilizer, sir, I know. Second mood stabilizer, then after that third, then after that fourth, it goes on. Last time I showed you one slide where 7.8 drugs are needed for the management of nolicon, which, forget it. It's going to be. This where I said, you remember some time back I said, in bipolar disorder management, any question anybody asks, you're right, that's a kind of a thing. That is it like. So we can't keep on adding that. 7 drugs, 4 drugs, 3 drugs. But at the end of the day, if it is completely effective, I'll be with you. But here, you tell me now, should I continue lithium while patient is on 11 years, already out of 25 years, I was talking about the renal toxicity. He's on for 11 years, he's on that. And in 11 years, he had 5 episodes. Do you want me to continue lithium or stop? If I stop, what is the alternative drug you are telling me? Please don't say oxcarbazepine, carbamazepine, and then valproate, sir. Give me a better drug than lithium. I am with you. I don't have a choice. I don't have a choice. I won't stop. I'll continue. But if you are in some others, suppose you see it's a random example I'm giving. Suppose you see a hypertensive here, if somebody is being giving a drug, hypertension is not under control, frequent exacerbations, and the doctor is continuing the same drug. What will you talk to the physician? What will you think about the physician? Whatever you think, anyway, leave it. This is the same thing, description about this previous patient. First episode, mania, he came to me. Then depression, mania, slightly prolonged, clear-cut depressions. But this is the only one, 2016, which went on for 1 year. Right? He was on lithium from this point of time. Not a single day, sir. Not a single day he missed. Even in the worst of times, rarely with haloperidol and then ECT, I continued lithium. And this is the episode he had. Now he's in business. This is the picture of this boy whom I have just shown. Now, the next few minutes, I think I showed you first slide. This again, this diagnosis bipolar here. He had only 1 episode. After that, as somebody commented, did lithium cure bipolar disorder? Such a wonderful thing. But in the previous patient, what was lithium doing? I don't know. This patient is also, I don't know. 2014, he came to me. 2020, as on today, he didn't have a single episode. I'm continuing lithium. If you ask me, how long do you continue? I don't know. How long should I continue? Maybe some suggestion, both. Now, let me talk about a few things. Good prognosis. This man who came to me, 30 years now, he retired as a bank manager. Bipolar disorder is a good prognosis disorder. This boy who came to me in 2014, he completed his BTech, MS, he is working in UK as a software professional, bipolar disorder, good prognosis. The other lady, where she was asked to resign, she functioned as a software engineer till recently. The other boy who had 5, 6 episodes or 7 episodes in, he is taking care of his business right now. What do you want? This is a good prognosis. Bipolar disorder, it's a good prognosis disorder. There is no doubt about it. After so many years, they are functioning so good. This is important. This I always keep telling every presentation of mine. I keep telling that this being one of the long-term disorders, age of onset is this. This is a major. It's a point which makes us feel cry. Why this only psychiatric disorder starts so early? Diabetes, hypertension, cardiac disorder start at 40, 50. See, the first patient, second patient, third, fourth, fifth. This is the age of onset. And then we are supposed to be giving them prophylaxis for the rest of their lives. And then surprisingly, actually, I tell you frankly, actually, when I took the first two cases and then third one and then I was not very selective on that, but each one representative of one I took. Ultimately, I ended up almost all the patients are on lithium. But I'll tell you one thing here. This patient came to me while on lithium. This patient, given a choice, I would not have started lithium because somebody asked me to start it. The third patient, actually, I discussed in the very, very first session along with this patient. Along with this patient, I discussed. Some of you may not know. Here, again, with a diagnosis, doubtful diagnosis of mania, I started lithium. Fortunately, I stopped. She's doing well. Here, every time I gave lithium, only when there's a doubtful mania diagnosis, irritable mania diagnosis. Here, definitely, I started lithium. All the 5 patients of mine were on lithium. Each patient, you see the variation in the response. It's not the same. Right. This is the patient we discussed in detail. Right? 3 episodes. This is the last patient I discussed. And this is one patient some time back I discussed. I'll quickly run through that. This is again a young lady, 15 years. She had 1 episode before coming to me, spontaneous remission supposedly. 2nd episode, paroxysm improved. 3rd episode, I had a lot of problem in managing this, where this irritability again created a problem. That's where I started lithium. Fortunately for her, she developed a physical problem and forced to stop all the medicines. And then episode came with a significant, severe depressive episode where I had to start on clomipramine because I was a little bit hesitant to start SSRIs while the patient was on anticoagulants. But with clomipramine, she recovered and there's no relapse. This is where I got the confidence. No, I don't think this is bipolar. I think this seemed to be a recurrent depression. 2016, again, she came with a depressive episode. Now she's continued on 10 milligrams. As on today, she completed her post-graduation. She's doing a job. This is what. These are the 3 cases. It's a little bit cluttered slide. These are the 3 cases which I've shown. So now in these cases, I leave it to you open. The variety of presentation. And then this is not just an academic exercise. When we have a doubt about this irritability coming in picture and bipolar disorder diagnosis, therapeutically, we are making gross mistakes in not starting antidepressants, giving antipsychotics and so-called mood stabilizers and creating problems. See how smoothly she improved and then how this is my work of art. If I were very clear about depression, I would not have created this problem for this lady. This anyway is not in my hands. It happened like that. This here, fortunately for some other reason, we stopped this. Otherwise I would have continued. So these are the factors. Of course, we operate with some limitations. There is no diagnostic test for us. We operate with that. End of the day, what I say is that early onset, that becomes a very, very important thing. We have to be very careful how long we give the medicines. And then always we look at complete recovery where you make it a symptomatic recovery. They'll have their own functional recovery. They do very well in bipolar disorder. These are the variety of presentations, how frequently we make mistakes. Then the tentative diagnosis of bipolar disorder, and then bipolar 2, and then bipolar spectrum, and then soft bipolar, and then possible bipolar, probable bipolar, and then later rapid cycle, and then cycle acceleration. This is the therapeutic disasters. This is the therapeutic disasters. See, otherwise, quiet improvement. See, this is what happened. See, this is what happened. This is because of our confusion in our diagnostic criteria and then lack of clarity. That is what is happening. That is where, and I said that diagnosis dictates therapeutics. And diagnosis can make such a big problems here in that. So we have to be careful in that. These are some of the lessons what I see that now, like, and what I can learn. And then maybe let's take some more questions if there are any of these things, and breakthrough. How do we convince the relatives when, yeah, it's a big problem. How do you convince the relatives when the patient has relapses despite regular medication? It's a serious question. Last time I showed a slide. An young girl presented with bipolar mania. Will he become all right? Yes, he will become all right. Complete recovery. Is he going to get next episode? Yes, possibility. Doctor, can you do something so that my child will not have a next episode? Yes, we will do. How much confidence we have in this so-called prophylactic drugs? Are you confident? And the patient is taking, fortunately for us, sir, I'm telling you, fortunately for us, most of our patients are non-compliant with drugs. So that is why every time he stops the drug and we happily say that you stopped and you got a relapse. You got stopped and you got a recurrence. Sir, there are patients who take it regularly and then they ask, doctor, I've been taking regularly. Why? If I'm going to get in spite of this drug, why are you giving this drug, doctor? It's a difficult question. And it's not an uncommon thing. If it is once in a while rare phenomena, medicine, a lot of times it happens. We can't answer. But this is a regular phenomenon. Every second day phenomenon. At least a group of patients. Out of 10 patients I keep the patients on lithium. Can I say at least 6 or 7 patients, you will not have next episode? No, I don't have the confidence. Then what are we talking about prophylaxis? Why are we talking about prophylaxis? For whose sake? I don't have a choice. Because you don't have a choice, you do keep the patient on lifelong medication. It's not correct, sir. Let us have a documented evidence-based thing. Show a 10-year-old crossover study. We definitely, everybody wants prophylaxis is the most important thing in medicine for you, for me, for the patient, for the relatives, everybody. You don't have that and keep talking about this and then extrapolating data from here, there, and all things. It becomes, for a clinician, I have to answer. I have to answer every day and I have to look at the data there. On lithium and quetiapine for 9 years, the patient had 6 episodes. If the relative of the patient, the doctor asked, what are we doing, doctor? What do you want me to answer? Yes. We'll answer, but like, is there a problem? Is it mandatory? No, I don't stop lithium. Sometimes we give. Impulsive behavior, nice, sir. Valproate and all things we have been giving carbamazepine and then oxcarbazepine and then valproate. How effective it is, I don't know, sir. Lithium-induced diabetes insipidus. This is a relatively minor problem. So I don't like, maybe I give much more importance to the lithium-induced tremors, and then like an acne is one thing. A lot of patients stop lithium because of that. This is reasonable. If patient develops that, fine. I explained that this is the reason because of lithium you have developed this, and you go back to your physician. Definitely they'll take care of it. I don't know. I think it's an excellent question. I'm sorry. And see, like, there are two things. Am I being a little bit too finicky about the effect of prophylaxis? I'm being too much asking for too much. I don't know, but I don't think I'm asking for too much. I need some. See, when you treat a patient with tuberculosis or like typhoid or diabetes, you say clearly this is the thing. What is the factor which was consistently observed? Textbooks told us elated, grandiose, no psychosis, no substance abuse, MDE pattern, all those things have been told. But all those things, I don't find it a consistent factor. No, it doesn't. But there are some patients who respond to lithium. Who are those? What is the group? Which is going to be a kind of a question which we have to trial and error. But this trial and error, how long, these are the little bit of a problems. Why I'm talking this is, diagnose bipolar disorder. Number one, if it is irritability, be careful. Number two, diagnose bipolar disorder, start on so-called mood stabilizer, and let us stop that. For the patient's sake, for our own conscience sake, let us be a little bit more scientific in our approach. Obese young males with bipolar disorder, why lithium can be given. Lithium doesn't increase the weight so much. Valproate increases, and olanzapine on some people it increases, but not everybody. So I think these are some of the questions what we have, and then that is where kindling hypothesis. Yeah, I think somebody asked. This was once, I think, 3-4 decades back. One theory randomly put forward for bipolar disorder as kindling hypothesis, similar to epilepsy, and then that is the introduction. How anti-epileptic drugs made its introduction into psychiatry and then mood disorders, looking at it as episodes, kindling, and then carbamazepine thrown out, oxcarbazepine thrown out, lamotrigine, you have equal evidence this side and then that side. Valproate, which is consistently being given, FDA does not have approval. A lot of questions being raised about it. First of all, kindling, does it really explain? I don't know. I don't know about that. But one thing I'll tell you. Unlike schizophrenia, I don't know much about schizophrenia because I don't deal many cases. But generally, schizophrenia is supposed to be continuous, slow. If not a downhill course, I come down and then come. Bipolar disorder, in my experience, majority of the patients is not like that. Each episode he recovers. He'll come back to like you and me. Unless you pump him with polypharmacy and then produce side effects. And he'll function like you and me. 6th, 5th, any number. So you have 100 episodes. See, 100 episodes, many episodes will always know, like, one fracture, I can get back and then run marathon. If I have 20 fractures, it's a common sense that I'll have a bit of a difficulty. It's in a sense. Continuously, every episode leaves a scar inside. I don't see that. I've seen a lot. Even this boy, you see that this boy himself, after so many episodes and all, he has been functioning excellently well. And I kept him only on lithium. That's very good. This is something which you see in psychiatry only in mood disorders. No other disorder you see this kind of a return to premorbid symptomatic recovery, not a single symptom. YMRS less than 8, HAM-D less than 7. You don't see in majority of almost any other. I was asking last time also, child psychiatry, you don't see much. Please don't get angry with me saying that child psychiatry entirely or geriatric dementia you don't get. And adult psychiatry also, like in milder anxieties, maybe major psychiatric disorders, it's a mood disorders where you see patient complete recovery. Look at this, 4 years. This boy was doing fantastically well. Absolutely euthymic, no problem. And then, right, the other patients I've shown that for many years they did very well. That is the beauty of mood disorders. Right. Does bipolar disorder requires lifelong treatment? I'll leave the question. I'll put the question again to whoever is the audience who is here. This lifelong business is something. Diabetes, I agree, lifelong. Hypertension, maybe I agree for lifelong. But bipolar disorder, I have a major question on that. If the drug is protecting, let's see that. This patient, let's look at, you started him on lithium. Suppose he didn't have any of these episodes. Previously, up to here, let's see. Before starting lithium, he had these episodes. Now you started lithium, almost no episode, maybe, or just one here, or almost, then definitely I say lifelong. Undoubtedly I say lifelong because it's worth it. If it is not that, then problem. So I don't have an answer. Bipolar disorder with epilepsy, right? And you treat epilepsy? Valproate, supposedly helpful. I don't think it's much helpful. Okay, give it. There's no problem at all. And lamotrigine is a very safe drug, but for that initial rash, you can give that if it is going to be, if you feel that it's effective anti-epileptic drug. What is your experience with bipolar disorder, psychotic symptoms like dissolve? Whatever the picture, whatever the clinical picture in either in mania or depression, if it is a diagnosis of bipolar disorder, whatever the gross symptoms, really psychotic symptoms, they will recover. whether it is disorganized. There, I think that I have shown some time back also paper. The clinical characteristics do not differentiate the episode recovery. Psychotic mania, non-psychotic mania, fifth episode mania, first episode mania, there's not much of a difference. They recover. Just that we common sense says that no, it cannot be, but in the clinical sense, it is definitely. Depot injections when it's not, maybe temporarily you can use, definitely you can use. Maybe for a shorter period. Many patients are extremely uncooperative patients, maybe 2-3 months you can use. But beyond that, as a long-term prophylaxis in this, even the role of depot LAs in the management of acute mania, there's some doubt. One of the recent papers says that we need more evidence. Long term, I don't want to give because as it was that most commonly used drug is risperidone, paliperidone, which I feel that it can produce drug-induced depression. That's my problem. And then first generation antipsychotics, I don't want to give LAs. So I'm left with only olanzapine. Olanzapine can be given if this is a patient who has responded with olanzapine in acute care and does not have weight gain. Absolutely, you can give. But for that disequilibrium syndrome, you can take care of that. But that can be. But how much of experience? I can't say that. Yeah, I said that. Which depot? If you force me to that, I'll go for olanzapine. Only thing is, should not produce a weight gain. I would definitely go. Actually, olanzapine, if you leave lithium, if you leave valproate, if you force me some other drug, you tell me, I would rather go for olanzapine as a prophylactic drug also. So might as well go to long-acting olanzapine. All right. This question, is there any need of adding antipsychotic along with lithium in mania with psychotic features? I'll put this question other way, sir. Is there any need for adding lithium for antipsychotics in mania with psychotic features? If you give me the choice, I'll treat this patient only with antipsychotics. I'll not give lithium. But you can't treat this patient only with lithium without antipsychotics. That's a problem. That's a problem. That is what I showed, which case, let me leave it, this case, I'm sorry. All right, I'll show you. This is the case. I think if you have some time, some of you who are not there, this is the boy I was saying that now, like, which is this boy? Okay, right. This is the boy. This case is lithium in the process of curing BD. This case is this boy. 23-year-old BTech, first time he came to me, clear-cut mania, John Cates, elated grandiose mania, only 3 weeks. I gave only this. That time, a lot of people asked me, why are you giving only risperidone? Why you didn't give this? How can you treat mania with risperidone? I said very clearly, sir, monotherapy, I give only risperidone or olanzapine. I would prefer to treat that. Why should I use polypharmacy here? I'll use a monotherapy. And this patient recovered. This patient, yeah, within 20 days, 15 days, depression he developed, which I thought, again, I was talking to you about drug-induced depression, which I thought it is risperidone-induced. So I pulled out, I wanted to pull out risperidone, but now here lithium has come into the picture, mainly that patient's brother was a doctor. Don't think that these are all minor issues in the clinical practice. You have to. Brother comes and asks me, doctor, what is this? You are running a bipolar clinic and all those things. We heard something about you. My brother is a bipolar disorder patient. You have not started him on a mood stabilizer, lithium. What is this? I said, yeah, I'll start. I don't have the guts to say that, no, I'm not going to, because I don't know. Now I can say, after 6 years, now suppose if this boy had another manic episode, where will I keep my head? Boy, brother has asked me to start lithium. I said no, in case. So unpredictable course of bipolar disorder is one of the things which is. So I started. Anyway, he's doing wonderfully good. This is where I said that 2014 to 2020, he didn't have either a manic or depressive episode. This is what I told that here. It's on the lighter side. Is lithium in the process of curing bipolar disorder of this boy? That's what I asked. I told you. Today, you have one episode of mania, diagnosis bipolar disorder. Perfect, right? What about the next? When is the next episode? You don't know. What is going to be the next episode? Depression, mania? You don't know. How severe is going to be the next episode, you can't predict. How long it's going to be, that is what our status is when these kind of things are happening. So it's so difficult to predict the next episode. So it becomes very, very difficult for me to say strictly no. I don't want to put this thing at risk here. Unfortunately, we're developed. So start this. Now, once you start this, it goes on. But here, I think we'll not go into the discussion again. Sometime I said that, can we think about stopping? But they didn't agree. But no, like it's going on like that. But maybe sometime each bipolar disorder patient, like there's something different. We have to look at it differently. The dictums of mood disorder, mood stabilization should go. Then we'll treat them depending on the number of episodes and all that. I think, right, thank you very much. I think all the questions are done. We have finished all that. Thank you very much. And then maybe just one or two, you're right. Somebody asked me, other than antidepressants like bupropion, yeah, I think it's being asked some time back also. Somehow, bupropion is a drug which produces less switch. That is what is told. For me, I will also equate, please don't mistake me, I am being rude, I will be rude sometimes. Bupropion is less switch inducing. I say that it's a least effective antidepressant. For me, it is not an antidepressant. If it is not an antidepressant, where is the question of producing a switch? So I don't consider bupropion. That is my personal opinion. I can't make such a glossary, but it may be effective in some. Elderly gentleman relapse every year. Oh, all right. Oh, okay, good. An elderly gentleman, bipolar disorder with manic symptoms every year. This is surprising. What age it started? That's again, we don't know. Last 3 years, every year a manic episode. Didn't tolerate valproate. Good. On olanzapine only. Responded well. Excellent. See that it doesn't produce increased weight. Rest of things already elderly man would have been a diabetic hypertensive. Don't worry about it. Now maybe on the minimal dose or whatever the optimum dose of olanzapine. Now he's back with mixed picture. Again, the problem is I'm a little bit uncomfortable with this mixed pictures. I always have some confusion about mixed picture. I never used to diagnose. Fortunately, DSM-5 has removed it. That's it. And you added fluoxetine. Fluoxetine again, he's 70, my God. I don't dare to add fluoxetine for somebody at 70 not because of the drug. 70, I expect generally these people to be on antihypertensive, anti-diabetic, statins, and some other aspirin, some of those things, multi-drugs. Fluoxetine is a significant drug-drug interactions. That's my worry. Go for escitalopram, my favorite drug, or go for sertraline. Fine. You can sort of manage with that. Or olanzapine itself may be smaller doses, depends on how severe the depression is. So depending on that, you can take a call. Add lithium for somebody at 70 years age. We have to, suppose again the same thing I told that. Suppose last 3 years, he has been having one manic episode every year. You start lithium, next 3 years, he doesn't have a manic episode. I'll vote for it. Definitely I'll vote for it. What's the problem? We can get a creatinine urea tested every 3rd month or 4 months. No problem at all. We can explain to. But if it is that effective, that's the question. Otherwise, is it correct to expose that old patient to this risk? That's the only way we have to deal with it. You can give it a try. Oh, somebody asked, why preferring lithium compared to sodium valproate, even though lithium has narrow therapeutic index? Sir, I think I have made it fairly clear. For me, as in today, if you ask me, prophylaxis in bipolar disorder, if there is something which can give a reasonably good prophylaxis, it's only lithium, nothing else. That's mostly my personal opinion. Other drugs, like largely they have failed us. Largely they have failed us. That's a problem, nothing else. The evidence, like plus minus, like evidence comes in the, that. But in lithium, there are a lot of problems, but lithium is one drug which I think we should, I think as somebody told, if you can't or if you won't give lithium, please get out of the business of treating bipolar disorders. I don't say that, but that is reasonably. And somebody said here, right, your experience with unipolar depression, sir. Right, anyway, I'm going to say good night to you. It's already 10:10. The next topic I'm looking at, I just want to put it across to you because the whole lot of my presentation, the central theme is there are 2 points. Mood disorders are good prognosis disorders. To reinvent, it's not nothing to do with me. It's the great man Kriplin has done about 100 years back to reinvent. That's one. Second thing is that under treatment of major depressive disorder and overdiagnosis and over treatment of bipolar disorder, this is one of the strong beliefs for me. Right, maybe right or wrong, that's what I strongly feel. The next topic I thought I'll do is that I did a part of it some time back. My title of my topic will be, I am depressed about depression. I am depressed about depression, which reasonably, I feel very sad about MDD. I did talk about 1 or 2 sessions before, but next topic will be, I am depressed about depression. I'm going to talk about few things about mostly, as you said, recurrent depressions and MDD, and then what is the kind of treatment, why there is 85% of mental health gap in the management of simple problem like major depressive disorder, which is so widely prevalent, 5% prevalence. That we'll talk about it, sir. Thank you very much. Thanks. I think it's great to be with you.